Hi, everyone. My name is E. David Crawford from the University of California in San Diego, and welcome to our PET tumor board. PET imaging, especially PSMA PET, in my opinion, is one of the most significant advances in prostate cancer management in the last decade. It has created a lot of opportunities and also challenges. I have observed that in many tumor or second opinion boards, almost half of the cases now are focused around PET scanning, particularly PSMA PET. We recently published our latest RaDaR 6 and 7 guidelines, which goes through in detail a lot of the indications for PET, the pitfalls and the ups and downs. We have a lot to learn, and we hope that these monthly tumor boards will broaden your knowledge in this area. I would like to thank Blue Earth Diagnostics, who recently developed and launched a PSMA PET product called rhPSMA or POSLUMA for this educational grant. We have gathered for this tumor board panel 3 international experts in this field. They have not seen these cases beforehand, and so they are as blinded as you are to what's going to happen in these cases. First panel member is Dr. Phil Koo. Phil is at MD Anderson Banner in Phoenix, Arizona. He is a nuclear medicine physician. Also, Dr. Daniel Petrolak, a medical oncologist from Yale, well known in the field of prostate cancer, is joining us. And a radiation oncologist, Dr. Paul Wynn from Harvard Brigham in Boston, Massachusetts. So, gentlemen, let's go ahead and get started. This is a 68-year-old male who had a PSA of 6.2. He had bilateral Gleason break group 2 and 3 and 4 of 12 cores. He underwent a radical prostatectomy in a small town north of San Diego in 2020. Okay, and this was a robotic prostatectomy. His nadir PSA really never got down to undetectable. And it was, in fact, 0.8 in 2021. It continued to rise, and his PSA in November of 22 was 1.54. Another repeat was 1.52. And so he came to see me in January of 23. So the issue is, what's next? Let me ask Dr. Petrolak, what's next with this guy?
Clearly, we want to image this patient since, number one, there's a very high chance of him having micrometastatic disease or actually obvious metastatic disease, since his PSA never went to less than 0.1. He's now got a PSA of 1.52. So my next step would be to image this patient with a PSMA PET scan.
Okay. Paul?
Yes, I agree. I think if you have access to a PSMA PET, that'd be the way to go here.
All right. Well, you guys are right on. We did that. And this is this PSMA PET. And now we're going to have to call on Dr. Koo to help us out here. What's going on? This was done on 2/6.
So on February 6th, we have several axial images of the fused images that overlay the PET image with the CT image, and these are sort of snapshots taken from that. The first image that we see on the left has that circle or region of interest around a rib lesion in one of the right, maybe second or third ribs. Looking at the semi-quantitative parameters, it shows an SUV max of 1.9, which is relatively low. And I presume this is the only rib lesion that was seen Otherwise, I
He
assume
had two rib lesions. I don't have them both here, but
He
they,
had two.
yeah.
All right. So if he had two, if he had one, I would look at the CT carefully, make sure we're not seeing anything abnormal, and ignore it as benign. If we have two and they're all kind of this low level and there's nothing on CT, I still will be a little bit more inclined to call this benign and not metastatic disease for the time being. And then I often like to synthesize the clinical information before I come to my final diagnosis. Then we have the middle image. We have something focal in that right iliac bone that's much more intense. I'd want to look at the CT carefully to see if we're seeing anything on the CT. But this in and of itself is a little bit more suspicious for metastatic disease. And then the image on the right, screen right, we have a subtle focus of activity, presumably in the left aspect of the prostate gland, which might be an area of recurrence.
So just for our audience to know, the faculty have not seen these cases or heard them before we started. So Phil is looking at this cold, and that you got it, you nailed it. Rib lesions, the iliac, and then something in his prostate. That's not the whole story, but why don't you comment on the rib lesions? Because I see that all the time. Somebody's got something and then they get nervous, and ribs aren't positive rib lesions seem to be seen quite a bit.
Yeah, I think rib lesions have really been confounding. And I think those who are sort of earlier in the learning curve often call these Mets just because they see activity. But what we're learning is that solitary foci of activity, focus of activity in a solitary rib lesion, more often than not, almost 100% are benign. But the more you have and the more intense they are, I think the suspicion goes up. You also want to make sure you're looking at the CT carefully, because oftentimes a prostate met, if it has more destruction or if it's sclerotic or something like that, might push you towards calling that a metastatic lesion versus a benign lesion. But we know the ribs often have very often benign fibroosseous type lesions.
Okay, Paul, what are your thoughts?
Yeah, so now we have a patient with oligo-recurrent metastatic prostate cancer. He's got at least 2 or maybe 3 metastases, but he also has now this lesion in the prostate bed. So that complicates things a little bit.
Remember, he's had a radical.
Right, and you're right. He's had his radical. So it complicates things a little bit. So one option is we do SBRT to these oligometastatic lesions, and the basis for that is the STOMP trial and the Oriole trial that says you can delay ADT, so Dan doesn't have to start his drugs. So that's one option. Another way to look at it is the COMET trial looked at these kinds of patients and said, if you do SBRT to those bone metastases, as long as they have a controlled primary, you might even be able to make them live longer.
Right.
In this case, the tough thing is he's still got that prostate bed lesion, and I'm a little bit hesitant to treat that because that's going to cause more side effects. So to be consistent with the COMET trial, I might have to actually, if he was super young and wanted to be super aggressive, I could actually treat the prostate bed like the prostate fossa and then do SBRT to those bone lesions. But in that case, we're really doing comprehensive treatment. So I would want to talk to Dan about maybe doing some ADT with that. So many different possibilities here, from minimal radiation to maximal radiation with ADT.
Dan?
Yeah, I mean, one of the things that concerns me about this patient is the fact that this patient never went to less than 0.1. And that to me would indicate that there may be more micrometastatic disease present than what we see on these particular scans. So I would definitely consider focal radiation therapy to all 3 of these particular spots, but I would also go along with ADT as well. And the question would be, how much ADT do you want to give this particular patient? How intense should it be? I probably would give a next generation anti-androgen along with the ADT, and then perhaps at a year re-image this patient and see what's happened. Does he have these lesions? Have these lesions improved? Are these the only lesions present? Has he developed new lesions over that time?
Okay. Well, I presented this case at the tumor board earlier in the year, and they said the same thing you all said. Radiate ADT, radiate the prostate bed, and radiate the right ileum and the pelvic lymph nodes. And so the discussion is, your opinion, you would sounds like everybody pretty much do the same thing, right?
I would do this for a select patient, a young, healthy patient that really wanted to be super aggressive. Partially because we are kind of extrapolating from data a little bit. We don't technically have data to fully support this in the post-op setting like we do in the upfront setting, where if you have micrometastatic disease, you can radiate the prostate and get a survival benefit. You can radiate the bones and get a survival benefit. And Dan can add his special ADT and get a survival benefit. So there's a little extrapolation here, but I would support this for the right kind of patient.
Okay. Well, everybody sort of felt that they would try to, use ADT or radiate the areas and that. And I think it makes sense. Well, this patient and I were somewhat curious about things. So we discussed with him getting a MRI, maybe biopsying that ilium bone. And I did something that we don't do much anymore. I did a rectal exam on him, and one could feel not a hard mass, but some sort of tissue that was there. Just felt like normal prostate to me. So the multiparametric MRI shows, and you can't see very well here, a 12-centimeter mass at the bladder neck. And the ilium biopsies were negative. Now what? Paul?
Wow. So that mass is way bigger than I would have expected, given what we saw in the PSMA PET. And I guess if he doesn't have the ilium mass now, and we're not sure about the ribs, maybe he just has purely local disease. So in that case, I'd talk to Phil first and kind of get his opinion whether there's any metastatic disease to be worried about. But if not, then I would consider doing pelvic nodal radiation and then very aggressive local radiation to this area.
Okay.
This is interesting because they were aggressive and tried to get a tissue sample of that ilium lesion. But I imagine on CT it wasn't visible. And most places in IR, when they're doing these biopsies, it's under CT guidance for a lesion like that. And if you don't really know what the target is, you're doing more cognitive fusion. And whether or not you actually target a lesion, it's hard to confirm. So I think we have to question whether or not we were able to get that lesion or not.
Yeah, that's always the question. Yeah, I didn't show. I have the videos of it and everything, and it looked like they did everything they can to get that and so forth. But so anyway, he did that, and I said, well, what next? So I said, why don't we get an oximum scan on this guy? So he's had a PET. Let's go back and see what that shows. In fact, what we see here right now is there is nothing in the ilium that lights up on the oximum scan, nothing in the ribs. And now you can see this mass in the prostate. So there's more focal uptake. And you want to comment on that at all, Phil?
Sure. This is really interesting. And I think we're still learning a lot more about how these different radio tracers are complementary, how they're the same and how they're different. There was that study from Jeremy that did a head-to-head study between Axiom and PSMA that did show that for local recurrence, perhaps Axiom performed better than PSMA. So you get a study like this, you're seeing clearly more robust activity in that prostate bed. I think and now that we have the MRI, I think this really shows a nice picture of that recurrence in that prostate bed. And that ilio lesion, yeah, I think it's hard to explain.
Okay. Paul, any comments? Or Dan?
I mean, the ilio lesion is hard to explain. Also, again, when you look at all these scans, you've got to take the history into consideration. And I'm still very concerned about the fact that this patient never had a PSA that had reached less than 0.1. And that would lend me to be a little bit more aggressive. So in this situation, 6 months of ADT plus radiation, I think is appropriate. And then you certainly could watch the patient afterwards and then reinstitute ADT if this patient does have some evidence of biochemical relapse. We had a case almost like this, except the duration of time from the prostatectomy to the time the patient had a PSA relapse was much, much longer. He also had a rib lesion. We just simply focused on the bed and he wound up having an undetectable PSA. His testosterone level is now normal, and it's not, his PSA has not risen. So you've got to use the history.
So what happened was I decided to biopsy the prostate or whatever was there, which was pretty easy to do. The guy had not any radiation. The biopsies all came back as BPH and inflammation and no prostate cancer. And the other funny thing was I could never get his path report from the doctor that did it. And those, being a urologist that's done a lot of radical prostatectomies, and I've seen a lot, I've seen a number of cases in my career where, particularly with robots, where they left behind half of the prostate. And so this guy is a guy who had these biopsies I'm showing you right here. So I think what we're dealing with here is that all of this stuff, I mean, the lesson here is the scans are not perfect. You have false positives. The tumor board wanted to rate everything. Paul, you know Paul Siebert, right? Yeah, radiation oncologist here. I mean, he was just all over radiating this. And when I
was ready to light him up as well. You had me, David.
And Paul's, so we had a nice discussion about that. So I think you gotta sometimes think outside the box, and that there are false positives with the test. There's still a role for oxymum. The oxymum had a homogeneous uptake. It didn't look like it was a sort of scattered cancer thing, and it did not show. And it's looking for a different thing. But we've got a lot of tools, and I think we had to use them. And this guy, I just kind of smelled a rat with this guy from the beginning, and it turned out we don't know. So what am I going to do with him now?
Yeah, Dave, how do you plan to re-image him? What radio tracer would you use?
I'd probably go back and use him. And if this PSA was really going up, I'd probably use a PET PSMA, but I think I could use this. Well, the question is, I mean, there are people I talked to some of my friends at MD Anderson and other about, would you go in and try to take this out or leave it in? And that's sort of all over the place what people say. But you know what I'm doing? I'm putting him on finasteride and to see what it does to his PSA if it cuts it in half for a while. And he's all for that. I think going in there and trying to, take this thing out right now, the guy's going to have some risk. But, I feel comfortable that, there could be some cancer in there. And I got seminal vesicle in the biopsy too. So there was nothing in there. Interesting case, huh?
That's a great case, David. I was really surprised. I did not expect that at all.
Medicine is humbling.
They used to use finasteride and then rebiopsy them after that, or at least use finasteride to potentially bring out a lesion. Yeah. Would you consider rebiopsy at some point, even though the PSA may be going down?
Yeah, I think so. I mean, if this is BPH, his PSA ought to cut in half pretty quickly, or benign tissue. But doesn't, he could have cancer hidden there. But come on, but I think you're right, Dan. You were right. Everybody's right on it. There's something wrong with that nadir, and we always think microscopic disease. The other learning curve here is you got to really think. These are great. The PSMA tests and oxymum are all great tests, but we gotta look at the clinical picture. So thank you all. It's a great discussion.